All right, we're putting you right in the hot seat today for one of the toughest tests any surgeon will face, the consultant viva. We're going to walk through a classic case, and we're not just going to talk about what to do, but the critical why behind every single decision. Let's get started. Okay, the clock starts now. The scenario's on the table, and the examiners are staring right at you. How you structure your answer, your logic, your ability to stay calm under pressure, it all counts. So let's see how you do. And that's it. That is literally all you get. A 65-year-old man, sudden, severe belly pain. The ball is now in your court. Your mind should already be firing on all cylinders, building a framework for how you're going to tackle this. Your very first words are absolutely critical. I mean it. A scattered, panicked answer is a huge red flag to the examiners. What they want to see is a calm, systematic, and most importantly, a safe approach. This is where you prove you can think like a consultant.
And there it is, the first question. It's so open-ended, isn't it? It's designed to see how you think. A weaker candidate might jump straight to ordering scans or blurting out a diagnosis. But a strong candidate, they start right at the beginning, with the fundamentals.
The only correct way to start is with a structured history. You tell the examiner you're going to characterize the pain. The classic onset, provocation, quality, radiation, severity, and timing. Then you'd move on to associated symptoms. But crucially, for a man this age, you've got to dig into those vascular risk factors. Does he have heart disease? Is he a smoker? Starting this way immediately signals to the examiner that you're safe, you're thorough, and you're already thinking about the scariest possibilities. So, once you've gathered all that information from your history and a really focused physical exam, the next logical step is to build your differential diagnosis. And look, this isn't just about rattling off a list of diseases. It's a prioritized set of possibilities, from most likely to least, and just as important, from most dangerous to least. The examiner pushes you for that next step. They want to see if you've connected the dots. You've got an elderly man with sudden severe pain. So, what's at the very top of your list?
A fantastic answer prioritizes the killers, the things that can end this patient's life in a matter of hours. So right at the top, you're thinking acute mesenteric ischemia, given his age and that sudden severe pain. But you also have to list the other catastrophes, a perforated ulcer, really bad pancreatitis, a ruptured AAA, or even a heart attack, which can definitely present as abdominal pain. This shows you're thinking about every single life-threatening possibility first.
Now this right here is a classic surgical pearl. This is the money phrase, pain out of proportion to clinical findings. If this patient is writhing in agony, but you examine their belly and it's surprisingly soft with not much tenderness, man, your alarm bells for mesenteric ischemia need to be ringing off the hook. Saying that phrase in the exam shows a whole other level of clinical smarts.
Okay, so after some investigations, let's say a CT angiogram confirms your suspicion. The patient is rushed to the operating room. This is the moment where theory becomes very, very real. The decisions you make in the next hour will absolutely determine the outcome for this patient. You open the abdomen, and your suspicion is confirmed. You see a section of the small intestine that's dark, dusky. It's clearly dead. There's no saving it. That segment has to come out. The examiner is now going to pivot and grill you on your surgical technique.
The first step, obviously, is the resection. And as you can see here, a linear stapler is perfect for this. It lets you transect the bowel on either side of the dead segment. The key, and you have to say this, is that you're getting well into healthy, viable pink tissue. You need clean margins with a good blood supply.
Okay, the bad part's out. Now you have to restore continuity. You have to join the two healthy ends of the bowel back together. We call that an anastomosis. You carefully line up the bowel, you fire the stapler to create the new connection, and then you close the remaining opening. A really crucial step here, one that's easy to forget, is closing the defect in the mesentery, that fatty tissue, to prevent a nasty internal hernia later on.
And here's what you end up with: a beautiful, wide, functional, side-to-side anastomosis. But listen, just creating the connection is only half the job. Making sure it's perfect is the next critical step.
This is a safety step that examiners are just waiting to hear you say. Before you even think about closing the abdomen, you must meticulously inspect your work. You check that staple line for any hint of bleeding, you make sure the connection is wide open, and you double-check that the bowel you've joined is healthy and pink. Forgetting to say this in your answer? That's a major fail.
Now we get to a true consultant-level decision. Just because you can make an anastomosis doesn't mean you should.
If your patient is unstable, if they're septic, or if the remaining bowel tissue looks even a little bit questionable, the safest move is not to join it back together. Instead, you create a stoma. This damage control approach is a sign of real surgical maturity.
And this is what that looks like, creating a loop ileostomy. On the left, you see a loop of the small bowel being brought out through the abdominal wall. Then on the right, it's opened up and sutured to the skin. We call that maturing the stoma. This basically diverts everything away from a risky area, giving the patient time to recover before you go back for another operation to reconnect everything.
The operation's over, but your responsibility is not. Not by a long shot. The post-operative period is just as critical. The examiner wants to be sure you have a complete plan for managing the patient's recovery and that you're on the lookout for any potential problems.
A great answer covers all of this stuff. You'll talk about the basics, right? Slowly reintroducing food, getting the patient up and moving to prevent blood clots. But the points that really show you're thinking at a consultant level are the last two. You must say that you will personally review the final pathology report on that piece of bowel. And if it turns out to be cancer, you have to state that the case will be discussed in a multidisciplinary team meeting. That's non-negotiable.
And that leads us to the final part of the viva. The examiner wants to see if you can think beyond just this one operation. They're testing your ability to manage the patient's entire journey, not just a single episode in the OR.
And there's the final twist. The pathology report comes back and confirms the ischemia was actually caused by a malignant tumor. The whole game has changed. This isn't just about surgical recovery anymore. It's about cancer staging, chemotherapy, and long-term surveillance. This is what separates a good surgeon from a great consultant. So, what's your plan now?